When you think about a garden that's just sort of slowly drying out, the conventional wisdom is usually just to grab a watering can.
Right, yeah. You pour water on the surface and the soil looks damp for an hour or so and you call it a day.
Exactly. But the surface looks fine temporarily, while underneath the roots are literally starving.
Because the actual issue isn't a lack of surface water today, it's that the underlying irrigation system, that whole microscopic network delivering nutrients from below, has just completely degraded.
Yeah, and you can pour all the synthetic water you want on top, but until you fix that internal plumbing, you are fighting a losing
It's a
battle.
completely losing battle.
And that is essentially what modern medicine has been doing to female sexual health for decades. We've just been handing out the medical equivalent of watering cans.
We really have.
So welcome to today's deep dive. Today we are cutting through all the medical spa marketing to ask a very specific, somewhat taboo question for you.
And it's a question a lot of people are asking behind closed doors.
Seriously, can regenerative medicine, specifically this procedure known as the O shot, actually rebuild that internal plumbing and improve natural lubrication?
To even approach that, we have to look past the glossy brochures, right? The ones promising instant results. We need to dig into the actual biological reality of the problem this shot is trying to solve.
Right, and to do that, we brought a massive stack of sources today. We are pulling from clinical practice guidelines, medical spa websites like Dr. Ashraf Sabri's Intimiplasty System and the Labiaplasty Center of Los Angeles.
Plus some incredibly detailed, medically reviewed UBI notes.
Yep, and peer-reviewed journals, including a really fascinating frontier study on postmenopausal vaginal atrophy, a systematic review of platelet-rich plasma therapies from Dialnet, and finally the proceedings from a National Academies of Sciences, Engineering, and Medicine workshop.
That workshop on regenerative medicine and women's health is, well, it's eye-opening, to say the least.
It really is. So, our mission today is to find out exactly what the O-shot is, the biological mechanism behind it, and what the hard clinical data actually says. Okay, let's unpack this.
Let's do it.
Because whether you are navigating postpartum changes, menopause, or you're just insanely curious about regenerative medicine, this is a prime example of science using your body's own biology to heal itself.
But before we look at the shot itself, we have to understand the physical problem it's trying to fix.
Right. We're talking about a condition that a massive percentage of women face as they age, right? Particularly during perimenopause and menopause.
Exactly. Estrogen levels drop. Now, the old medical textbooks called it vulvovaginal atrophy, which...
Ugh, which is just a terrible, bleak term.
It's awful. Thankfully, today, clinical practice guidelines refer to it as genitourinary syndrome of menopause, or GSM.
GSM. Okay, that sounds a bit more clinical and less insulting.
Right, and that terminology shift is important because it reflects a better understanding of the physiological mechanism. You see, estrogen isn't just a reproductive hormone.
Oh.
No, it is the fundamental chemical messenger that tells vaginal tissue to stay plump, elastic, and dense with blood vessels.
So it's basically the manager telling the maintenance crew to keep working.
Exactly. And when that estrogen supply drops, the tissue literally stops maintaining itself. The mucosal lining thins out drastically. It loses its elasticity.
And that structural breakdown is what leads to severe dryness, micro tears, and dyspareunia, right?
Yes, dyspareunia, which is the clinical term for intense pain during intercourse.
Which is awful. And the traditional medical response to a woman reporting these symptoms has been, well, fairly dismissive, or at least highly limited.
Very limited. You might get a prescription for a messy, temporary topical cream, like your watering can analogy.
Right, or you get pushed towards systemic hormone replacement therapies. But a lot of women either cannot take synthetic hormones due to a history of certain cancers, or they don't want to deal with the systemic side effects.
Which forces the medical field to look past hormones entirely. And that is the exact gap that platelet-rich plasma, or PRP, is trying to fill.
Okay, so the O-shot, which is marketing shorthand for orgasm shot, by the way, is a completely non-hormonal intervention.
Entirely non-hormonal. It relies completely on the science of autologous tissue repair.
Autologous meaning it comes from your own body, right?
Exactly. And because it's from your own body, the risk of an allergic reaction or an immune rejection is virtually zero.
Okay, so the theory relies on platelets. We usually think of platelets as the body's natural first responder medics. Like you scrape your knee and platelets rush to the site to stop the bleeding.
To form a scab, right. But they do a lot more than just plug a hole.
What else are they doing?
They are essentially biological storage units packed with these specialized proteins called growth factors.
Okay.
In the clinical guidelines we're looking at, there are three primary growth factors involved here. You have PDGF, which is platelet-derived growth factor, VEGF, vascular endothelial growth factor, and FGF, fibroblast growth factor.
Okay, wait, let's avoid the alphabet soup here. Listing acronyms doesn't tell us how a dried-out tissue suddenly starts producing natural lubrication again.
Fair enough.
How do those three specific proteins actually change the physical structure of the tissue?
Well, it's all about a mechanism called angiogenesis.
Angiogenesis.
Okay, let's break down the roles. VEGF, the vascular factor, is the trigger for angiogenesis. It literally prompts your existing dormant blood vessels to sprout brand new microscopic branches.
Wow, so it's expanding the highway system for blood?
Precisely. Meanwhile, FGF, the fibroblast factor, instructs your cells to synthesize type 3 collagen.
Okay, so think of the aging vaginal lining, like a sponge that has dried out so much it's become brittle.
I like that analogy.
You can soak it in water, which is what synthetic lubricants do, but the sponge's physical structure is still degraded. It's going to dry out again immediately.
Right, because it can't hold the moisture.
But those growth factors act like a construction crew.
Yeah.
FGF weaves new, highly elastic collagen fibers directly into the sponge to rebuild its structure,
Yes.
while VEGF runs brand new plumbing lines straight to it.
And that combination of new structural scaffolding and increased blood flow directly translates to natural lubrication.
Because more blood flow means more moisture.
Exactly. In the human body, fluid follows blood flow. More microvessels in the mucosal tissue means the tissue can naturally engorge and hydrate itself from the inside out, just the way it did before the estrogen decline.
I mean, the biological theory makes perfect sense. Rebuilding the sponge is a much better strategy than just wetting the surface.
Absolutely.
But reading about angiogenesis on a medically reviewed UB note is very different from, actually walking into a clinic.
Oh, totally. The clinical reality is a whole different experience.
Yeah, let's talk about the physical reality of this procedure because the logistics sound intimidating. What actually happens to you in the room?
So the standard outpatient protocol takes about 30 to 60 minutes. The first step is a standard blood draw from the arm, usually just 10 to 20 milliliters.
Which is barely anything. I mean, a standard blood donation is closer to 500 milliliters.
Right, it's a very small amount. The practitioner then takes that small vial and puts it into a dual spin centrifuge.
And this isn't just shaking it up, right?
No, it relies on strict physics. The first spin operates like a heavy gravity well. Red blood cells are physically heavier and denser than the rest of the blood components.
Okay.
So that first high-speed spin pulls all the useless red cells to the bottom of the tube.
But you don't just want the leftover plasma sitting on top. You need to isolate the platelets themselves.
Exactly, which is the purpose of the second highly calibrated spin. It separates the platelet-poor plasma from the platelet-rich plasma.
Got it.
You are left with about 4 milliliters of liquid that is essentially a hyper-concentrated serum of those construction crew growth factors we talked about.
Okay, here's where we have to look very critically at what happens next.
Yeah.
Because taking that 4 milliliters of plasma and injecting it requires needles.
It does.
The protocol uses a 30-gauge needle, which is about 13 millimeters long, and the target zones are the anterior vaginal wall, the labia, and the clitoris. I have to pause here. We were talking about injecting into the clitoris, a structure with over 10,000 dense nerve endings.
It sounds alarming.
Extremely. Yet the medical spa sites, like the Labiaplasty Center of Los Angeles, claim this is barely a 2 out of 10 on the pain scale and requires zero downtime. How is that physically possible without general anesthesia?
It sounds completely contradictory, but the neurology of pain management makes it possible. Providers don't just use a standard needle stick.
Goodness.
They apply incredibly potent compounded topical numbing creams and local anesthetics to the mucosal tissue first.
Okay, but still.
But the real mechanism that makes this tolerable is something called vibration analgesia.
Oh, I've seen that mentioned in dental journals, actually. The gate control theory of pain.
That's the exact mechanism. The practitioner applies a strong vibrating device right next to the injection site.
How did that help?
Well, your nervous system is basically a highway to the brain. The physical sensation of vibration travels along large, myelinated nerve fibers, which move signals very quickly. The sensation of sharp pain, on the other hand, travels along smaller, slower nerve fibers.
So the intense vibration signal gets to the spinal cord first and essentially closes the gate.
Exactly. It creates a neurological traffic jam, blocking the sharp pain signal from ever reaching the brain's pain centers.
Wow. So you don't feel the needle piercing the tissue at all.
You might feel a strange pressure, a sense of fullness that can last for a couple of days as the fluid sits in the tissue, but the sharp, stabbing sensation is neurologically blocked.
That is fascinating.
And because it's a localized, non-surgical intervention, the clinical sites are generally accurate when they say you can resume normal activities immediately, including intimacy.
Though, from a pure tissue healing standpoint, waiting 24 to 48 hours is standard medical advice, right?
Yes, give the tissue a minute to settle.
And as for the timeline, those growth factors don't build new blood vessels overnight.
Now, angiogenesis takes time. The clinical data suggest patients start feeling the shift in lubrication and tissue elasticity between 2 to 6 weeks,
And how long does that last?
with effects lasting anywhere from 12 months up to 3 years, depending on how quickly their individual biology breaks down the new collagen.
Okay, so that brings us to the critical turning point in this evaluation. We know how it's supposed to work. We know what happens in the clinic.
Right.
But when we strip away the glossy spa marketing, promising intense orgasms and instant cures, does this liquid gold actually perform in a controlled, peer-reviewed setting?
To answer that, we have to turn to a highly compelling study published in the journal Frontiers.
Okay, what do they do?
The researchers didn't just look at a random sample of women. They specifically targeted 66 postmenopausal patients suffering from severe vulvovaginal atrophy.
Severe GSM. Okay.
And the way they split the groups is what makes this data so vital for anyone considering the procedure.
How did they split them?
They took 36 women and put them on a standard regimen of topical estrogen creams.
The control group, essentially.
Right. The other 30 women were a very specific cohort. They had already tried topical estrogen in the past, and their bodies had completely failed to respond to it.
Oh, wow. So their tissue was essentially estrogen resistant.
Exactly. The researchers gave those 30 treatment-resistant women the PRP injections instead.
And over 12 weeks, they tracked them using 2 standardized medical metrics: the Female Sexual Function Index, or FSFI, and the Vulvovaginal Symptoms Questionnaire, the VSQ.
Yes. They aren't just asking, do you feel better? They are meticulously measuring vaginal pH, tissue hydration, pain levels, and elasticity.
That is rigorous. So what were the results?
The results were striking. Even though the PRP group was made up of women with the most stubborn, treatment-resistant symptoms, they showed statistically significant improvements over the estrogen group.
Wait, really? Better than the estrogen group?
Yes. They tracked dramatic reductions in burning sensations and severe pain during sex. The actual mucosal tissue showed visible, measurable improvements in natural hydration.
So the autologous growth factors successfully rebuilt the sponge, even for women whose bodies had completely stopped listening to hormone signals.
They did. It's incredibly promising data.
But any rigorous deep dive requires us to look at the broader scientific landscape, not just a single successful trial.
Oh, absolutely. We have to be objective here.
While the Frontiers study and various clinical reports claim high success rates, some anecdotes are citing up to 80 or 90% patient satisfaction we have to confront a massive, glaring issue with the O-shot as an industry.
And that issue is detailed in a systematic review of platelet-rich plasma therapies published in DialNet.
Right. The researchers flag a phenomenon called clinical heterogeneity.
Which is a polite way of saying it's the Wild West.
The Wild West.
There is absolutely no standardized, universally enforced medical protocol for how to administer this therapy.
Which is terrifying when you think about the anatomy involved.
Yeah.
In the Frontier study, they injected 4 milliliters using a 13-millimeter needle over a specific number of sessions.
Right, a very specific protocol.
But because there's no standardized map, you could walk into a clinic tomorrow and the practitioner might decide to inject 10 milliliters. Or they might use a 2-millimeter needle depth instead of 13.
And that depth matters immensely. If a provider injects too superficially, the plasma just pools under the skin and does absolutely nothing for the deeper structural collagen.
And if they go too deep?
If they inject too deeply without understanding the precise layout of the clitoral nerve network, they risk nerve damage rather than nerve regeneration.
Wow. This total lack of standardization is exactly why regulatory bodies like the FDA still classify the O-shot as an investigational or off-label procedure.
Exactly. The basic science is solid, but the instruction manual hasn't been codified yet.
And because it's off-label, insurance companies almost universally refuse to cover it. You are paying thousands of dollars out of pocket for a regenerative therapy that the medical establishment is still figuring out how to standardize.
Which naturally leads to a much larger systemic question. Why?
Yeah, why?
Why is a treatment that relies on sound physiological mechanisms, angiogenesis, collagen synthesis, your own autologous cells still so unstandardized?
Why is a therapy that shows incredible clinical promise for natural lubrication and tissue repair still relegated to the off-label Wild West?
It's not a lack of scientific capability.
No, it's a historical data gap,
Yeah.
and it impacts you and half the global population on a fundamental level.
The proceedings from the National Academies of Sciences, Engineering, and Medicine workshop on regenerative medicine and women's health spell this out with sobering clarity.
When they do.
Historically, women have been systematically excluded from basic clinical research.
It's infuriating when you read the actual methodology from the 20th century. Researchers didn't just exclude female patients from clinical trials.
No, they went further than that.
They actively excluded female animal models, female mice and rats from the early lab stages.
Because the persistent argument from researchers was that fluctuating female hormones, the estrous cycle, made the resulting data too noisy or too complex to analyze cheaply.
So they established the biological baseline using male physiology and simply assumed it would map perfectly onto women.
They ignored half the population's biology because it was inconvenient for their spreadsheets.
That is just ugh. And the fallout of that exclusion is what we call the gender data gap.
Precisely. Conditions that are distinctly female-specific endometriosis, stress urinary incontinence, and the genitourinary syndrome of menopause that causes this severe dryness have been starved of basic research funding for decades compared to diseases that affect men.
You deserve evidence-based medical care that is explicitly tailored to your biology. The fact that top-tier researchers in the mid-2020s are still having to host national summits just to beg prestigious medical journals to disaggregate their trial data by sex.
Just to see if a basic cellular treatment works differently in women than in men.
Right. It shows exactly how deep this bias runs.
However, the National Academy's workshop isn't just a critique of the past. It highlights a massive paradigm shift happening right now.
Yes, regenerative therapies.
Despite their current growing pains with standardization, they represent a total pivot in women's healthcare.
Because we are finally moving away from the era of symptom masking and surgical overcompensation.
For decades, the solutions offered to women with pelvic floor issues or tissue degradation were highly invasive radical surgeries.
Doctors were implanting foreign materials, like surgical mesh, which triggered horrific, cascading complications and autoimmune responses in thousands of patients.
Or, on the other end of the spectrum, offering completely passive solutions like synthetic lubricants that do absolutely nothing to halt the cellular decay.
But regenerative medicine fundamentally changes the question.
It does. It asks, how can we give the underlying tissue the precise cellular instructions it needs to heal itself?
It's the ultimate realization of the garden metaphor we started with. We are finally developing the tools to fix the root system and the irrigation pipes, rather than just handing women a watering can and telling them to deal with it.
So synthesizing everything we've pulled from the clinical guidelines, the Frontier study, the DialNet review, and the national academies.
Wait, let me guess. It's a yes, but?
Does the O-shot actually improve natural lubrication? The most accurate answer is a heavily qualified yes.
The physiological mechanism is sound. Extracting your own concentrated platelets to force the localized synthesis of new blood vessels and collagen is a brilliant application of biology.
It really is. And for patients who have completely failed to respond to traditional estrogen therapies, the clinical trials demonstrate very real, statistically significant restorations of tissue hydration and elasticity alongside massive drops in pain.
But the qualification is vital. You have to approach this knowing you are stepping into the frontier of regenerative medicine.
Because the medical establishment historically underfunded women's health, the exact dosages, injection depths, and best practices are still being mapped out by individual pioneer clinics rather than unified medical boards.
So you have to aggressively vet your provider because the technique matters just as much as the plasma.
Absolutely.
Which leaves us with one final deeply provocative concept to consider from that National Academies workshop.
Oh, this is mind-bending.
The O-shot uses plasma from your arm to fix vaginal tissue. But researchers, like Caroline Gargett and her team, are currently looking directly at the regenerative powerhouse of the female body itself,
The uterus.
specifically the endometrial lining. For decades, menstrual fluid was treated by the medical establishment as sheer biological waste.
Something to just be discarded and ignored.
But it turns out it is teeming with incredibly potent, non-invasive adult stem cells.
And researchers are now actively extracting those specific stem cells from menstrual fluid.
And they aren't just studying them in a petri dish either.
No, they are using them to grow 3D endometrial gland organoids in the laboratory.
An organoid is essentially a miniature, simplified version of an organ produced in vitro. They are literally growing complex, three-dimensional female tissue models outside the body to figure out how these cells interact, how they degrade, and how they rebuild.
If medical science can currently take a simple vial of blood from your arm, spin it down, and successfully use those generalized growth factors to restore localized blood flow and natural lubrication today,
Think about the trajectory we are on.
imagine what happens over the next decade as researchers finally unlock the highly specialized, profound, regenerative power of the endometrial stem cells.
Imagine using the body's own localized, perfectly adapted cellular blueprints to finally cure the chronic, debilitating pelvic diseases that the medical establishment ignored because they thought the data was too complex to bother with.
It makes you wonder how many revolutionary cures we've delayed just by refusing to look closely enough at the biology right in front of us.
Something for you to ponder.
The internal plumbing has always contained the inherent capacity to repair itself. Science just finally decided to learn how to turn the wrench.
Next time you see a wilting garden, remember, the real magic isn't in the watering can, it's in the roots.